Thanks.
Thank you so much, Dr. Gupta, for having me here. No, I think I'll break it down into three parts. Something that we have been doing, then how does the field look like in general, and the very important part, that how does it look for the patient. So our work started out in ICUs. I basically have a background in medicine, did a PhD in computational biology, have been doing data science and AI/ML for healthcare for the last 15 years or so now. Work collaboratively with AIMS, mostly in the Department of Pediatrics. So our work started in the Department of Pediatrics ICU, where we are predicting which baby, which child is going to crash in the next 24 hours with things like sepsis. We were developing models which are able to, we published our results, the solutions are actually deployed in the ICU as well. We were able to detect up to 8 hours ahead of time which babies are going to crash. But then we recognized one thing, we were missing a key piece, and that was what happens outside the ICU. A lot of readmissions into the ICU were happening from the walled part of the Delhi city, and that's an observation that clinicians made, which is when we started thinking about, okay, so if we really have to tackle the problem of sepsis, we need to really raise awareness, and can we use AI for this? That was the genesis of a project which we called Wash Karo. As you can see, it's a combination of Wash and Hindi and English. The idea was write information to the right people in the right format at the right time. A lot of us know that we don't read WHO reports or guidelines or ministry guidelines, right? So pretty much basically a general public would not read technical documents. So in 2019, we asked a question, and LLMs were not the flavor at that time. They were language models like BERT and Elmo. So we asked a question, can we use these language models to basically distill what WHO reports are saying, summarize them, convert them into Hindi, and then through an app, provide them as an audio format, a bite-sized audio piece of information, and compare it with what the news are saying. When COVID struck, we repurposed it for COVID, and we had 11,000 users within the 3 months, during which time the app was online. And most importantly, it was people who were giving thumbs up and thumbs down to the information provided. So we had 11,000 such pieces of information. Very interestingly, we saw that our models improved with thumbs up and thumbs down in terms of their tuning. But we found very interesting things like more females engaging with the app in Hindi than males. I mean, it is a barrier that we know still exists, right? Then we were able to also figure out some other things. So why am I saying this? Basically, this is pre-LLM phase. I don't know how many of you use ChatGPT. I use it every day. Okay, so 50% of the times the answers are wrong, or the answers have to be tweaked, or basically I have to prompt more to understand better. But it is a huge, I would say, aid to information mining, right? So is there a hope for LLMs? I completely believe that there is a lot of hope with the rider, that we need a lot of studies to be done to make it safe. The question is, are these studies easy to conduct? Probably not, because these are black box model. Every time you ask the same question, it will give a slightly different answer. So now what is happening is, since we have come to a point where this is now a well-known problem, hallucinations are a well-known problem in these AI models, something that is gaining popularity is called RAGs, Retrieval Augmented Generation. Basically, Google doesn't give you wrong answers. Why? Because it is just retrieving information. Is there a combination that's possible which will basically generate only on information retrieved which is trustworthy? And that's the next frontier. That's where I think the things are moving fast, and we need to conduct studies along those lines. I know I'm running out of time, so I'll just use 1 minute for the last part. Last 1 week, I was on the other side of the fence. I basically was dealing with the health of a family member with a dreaded disease, diagnosis of a dreaded disease. So basically I was on the side of the patient, right? And going from a hospital to another hospital, top hospitals, to basically understand what can be done in this stage of disease, right? After 4 days of going around and still being confused, I thought about asking ChatGPT. And I'm a doctor, so I understand a little better than a common person would. But to be honest with you, I actually came out much more informed about all of this if the right prompts were set. It needs a lot of work. Spent about a couple of hours initially, and then the whole day fine-tuning the process, but there is hope. So I think what we need to do is actually studies in India one point that I want to say that is, these models are strong where data exists. These models hallucinate where there are no data. If you pull out information about Dr. Shishendu Mukherjee as a Bollywood star, it will actually pull out that piece of information. Data doesn't exist, it will hallucinate. But if I ask about who is Dr. Shishendu Mukherjee, what does he do? Since he's so popular, more likely than not, it will pull out the right piece of information. It tells us that we need more patient-generated data to guide studies which make it safer for patients. And I'll stop.